Hello, everyone, and welcome to Keratoconus Conversations. This virtual event has been organised by the Ophthalmologist and is kindly supported by Avellino, Oculus and Glaukos. My name is Phoebe Harkin, Deputy Editor of the Ophthalmologist and moderator of this talk. I'm joined today by an esteemed panel of experts. May I introduce you to, in no particular order, Renato Ambrosio, world-class refractive surgeon, clinician scientist, and adjunct professor in ophthalmology at the Federal University of the State of Rio de Janeiro in Brazil. Next, we have Sam Garg, acclaimed Vice Chair of Clinical Ophthalmology and Professor in Cataract, Refractive, External Disease and Corneal Surgery at the Gavin Herbert Eye Institute at the University of California in America. And we have Farhad Afezi, renowned cataract and refractive surgeon and ocular cell biologist. Farhad holds professorships at the University of Geneva in Switzerland, the University of Southern California in Los Angeles, and Wenzhou University in China. And finally, we are joined by the incredibly accomplished Sufi Tineri, Director of the Center for Refractive Surgery, Munster in Germany, and owner of the Eye Department of St. Francis Hospital. Sufi also serves as lecturer at the Ruhr University in Bochum, Germany. So without further ado, let's get started. And what better place to begin than with global prevalence? So everybody, is keratoconus a rare condition? Does anyone want to take that question?
I'll start if that's okay. So, I think that definition has changed recently, and a lot of it by the work here of my friends and colleagues. Traditionally, it was thought that it was 1 in 2,000, and that's sort of the quoted rate of prevalence for keratoconus. I think through a lot of good work and a lot of important work, we know that it's much higher than that. And I think there's more tests that are coming down the line that will help us maybe recognize it even more. And depending on the area of where you live and the ethnic subdivisions, certainly it's higher in certain at-risk groups. So I'd love to hear what my other friends here think.
If I may start with an opinion, I think we should understand what is keratoconus and what is subclinical disease and predisposition or susceptibility for keratoconus, which a lot of people would refer as Frust disease. We have improved the diagnosis because of refractive surgery, and eventually we have to be keen on the understanding that we are not screening for keratoconus as a disease. We are eventually looking into the predisposition for the cornea to undergo ectasia. And when we apply that with screening tests in the general population, we start seeing people that are at risk for developing keratoconus based on some findings on tomography beyond front surface topography, and eventually biomechanics and other tests. And futurely, we'll talk about genetics for sure, but the incidence is going to be related to the method that we use for the clinical testing. And I think Farhad should comment on the study that he published in the British Journal of Ophthalmology about the incidence of keratoconus in Saudi Arabia, in a genetic hospital for pediatric center, that he saw a much higher incidence of that. And it echoes with other studies around the world.
Yeah, thank you, Renato. I fully agree with all your statements. What we have done 3 years ago was to go into the area of the world that has the highest prevalence, as far as we know, the Middle East, combined with more modern technology and then what was used in the 1986 Kennedy paper. And then indeed, we found a prevalence in the general population of pediatric and adolescent patients 6 to 19 years of 4.7%, which indeed is 1 in 21 instead of 1 in 2,000. So early detection means, on one hand, in my eyes, also, as Renato has said, to make the clear difference between what is subclinical, what is clinical, but also know the global prevalence. And the 2018 data have stimulated us to use our foundation, the Light for Sight Foundation, and start what we call the KMAP Global Prevalence Study. We have collected 8,000 eyes in 4 countries so far, and another 10 countries have started. Our aim is to collect Scheimpflug data of 50,000 eyes. The pandemic has slowed us down a bit, but as I said, 8,000 eyes collected so far. And thus we will have a global vision on keratoconus prevalence. And that's important on so many levels. If you better understand how much conus you really have in your country, you will be able to better assess the need for early screening programs, early treatment. The funding for research will be different. Think about diabetes. How much funding is there for diabetes, which is not a rare disease? So if we are able to change people's mind and bring keratoconus from the presumed rare disease to a not so rare disease at all, there will be more funding available. The last aspect I wanted to cover is that if we are able to understand that there is more keratoconus in some areas of the world, early screening becomes key. And early screening, in my eyes, means also give screening to the underprivileged. So another project we have started is what we call the SBK project, smartphone-based keratography. We are building a miniaturized placido-based topographer that can be worn like a helmet, where you can screen entire populations in remote areas or in low infrastructure areas of the world in a very efficient manner. And we try to figure out the whole chain from detecting an ectasia as to bringing the patient to treatment. So these are all aspects I think that are quite fascinating and that will change the way we perceive the disease in the next years.
Yes, I agree. Excellent work, Farhad. And I may add some aspect from not a real study. It was an informal survey conducted amongst the refractive surgeons within the Refractive Surgery Alliance almost 2 years ago. And those refractive surgeons were asked in how many people coming for refractive vision correction do you refuse to do LASIK because you are afraid of causing ectasia, or maybe there is even frank keratoconus. And the overall average was in 1 of 7 candidates for refractive surgery, LASIK is refused because of topographical changes that appear as keratoconus or subclinical keratoconus. So this is a 300 times higher rate than the 1 to 2,000 prevalence reported in the old literature. Of course, this is a special population, but still.
I think it's important to emphasize that detecting keratoconus is not the same thing as screening for ectasia risk prior to laser vision correction.
Absolutely.
And I have an example that I want to share with you. If I may, I want to share this case with you. It's a patient that I saw very recently at my clinic, and he came back after a few months. So I'll share my screen just quickly, and I think it's very informative in terms of what is going on. This is a 13-year-old male, actually a good soccer player. His father told me that he has a brilliant future as a soccer player, and he has 13 years old and 20/15 in the right eye and 20/60 in the left eye, and that's his corneal topography, the front surface placidus topography. And the right eye of this patient looks very normal. And eventually, this is the scale that I like to use, the one I designed. But if you use the other scale, the half diopter absolute scale, it's very much similar. So the patient is 20/15. So my first point is, in this asymmetric case, how the advanced imaging can help. Advanced imaging can help you understanding this patient has subclinical disease in the right eye. I confirm mild Fru's disease, as the TBI is higher than the normal cutoff value. So this cornea is a subclinical in the right eye. And of course, in the left eye, you don't need anything beyond, maybe even sleep lamp will be enough to diagnose keratoconus. But if you see the biomechanical metric here, when the patient first was seen by me, I told him you have a very high susceptibility for progression. So the first thing is don't rub your right eye at all. And I think you should do cross-linking as soon as possible in the left eye. And I definitely agree with Farhad Hafezi when he says that we should not lose time in such cases, because those cases, they come with a very high chance for losing vision. And this patient decided not to do surgery, but he understood the point that he needed a follow-up, and he comes back a few months later. And you see he came back last week, and this is February and this is August, and you see Kmax. Kmax has even reduced a little bit in the left eye. The right eye is still okay, but if you see the pattern in the more recent exam, you see more red here. And if you open here, you can see the subtraction map. So even though Kmax has decreased, there is a true steepening here, which is clearly seen in the ABCD progression. In both A and B and almost in the C, it reaches the sensitivity for being clinically significant, as the statistical repeatability test would show us. And actually the patient loses a little bit of vision. So this patient, I think the imaging technologies were very important for us to detect keratoconus in the right eye, eventually detect the high chances for ectasia progression in the left eye, and document this progression so that we don't lose more time and do the cross-linking as what we should have done. I really say that ectasia or keratoconus, we broke paradigms that are very important to be understood. And when I did my training, I only had transplant to indicate for those patients, and we would wait this patient to be very bad so that a transplant is worthwhile, because it was a penetrating keratoplasty. Even though today we have cross-linking, we have rings, we have many different procedures, and the paradox is that if you don't need surgery, you should not do it. But if you need, I think you should do as soon as possible. And this contradiction should be very well understood by the physicians when they manage such cases.
Renato, you are absolutely right, and I'm incredibly thankful for your display that you developed with Belin, and I use it every day in my clinic. So this cannot be overemphasized. This diagnosis has to be standardized. However, looking or diagnosing keratoconus is not equivalent with deciding upon the need or not need of surgery. And this is crucial, but nobody knows. At the time you diagnose, just looking at some map or the Belin-Ambrosio display, you cannot be sure if this will progress or not. So right now, we don't know if the disease will progress, if there is a need for cross-linking or not. So what you said is correct, but it's incredibly difficult to decide prospectively if there is a need for surgery. Retrospectively, it's very easy.
Yeah, I agree. I think very nice case, by the way, and it highlights so many important points. I think tomography is key. One advantage we have that a lot of places that don't treat keratoconus is the advantage of tomography, and to me, it's almost essential to be able to follow these patients and educate them, because I show them the maps and I show them what's going on here. This is going on in the front. This is going on in the back, and and they're all, well, this doctor told me I don't have keratoconus, or I may have keratoconus. The other thing I think you're highlighting here, Sufi, is that it's so multifactorial. There's many aspects that come into the possibility for progression, that you can't just depend on imaging, but you have to look at age, you have to look at certainly ethnicity, you have to look at habitual stuff. Are they eye rubbers, allergy, family history? I mean, there's so many things that we could keep talking about the whole hour on. But it's important to not just focus on one aspect of their diagnosis and say, okay, well, this is what I'm going to look at and decide on whether or not this patient should have treatment or not.
Thank you, Renato. This was really a nice example. I just wanted to give one more aspect to it, which is I think it's in humans' nature to always go for new technologies and to try what is possible. And if we take the example of SMILE, we know since some years that SMILE is biomechanically quite good. So what happens? We stretch the limit. We, as in refractive surgeons, we sometimes stretch the limits and say, okay, now I can include patients that I would have before maybe not included in my repertoire for LASIK, but if I do PRK or SMILE, I can. And what we have learned is that you can overstretch every system, even the best system. So you can have SMILE-induced ictasia, even PRK-induced ictasia. And so there is a thin red line that we have to maneuver between having better, more and better tools to really assess the patient and just driving a Ferrari in the very limit on a race course, trying to take even more 5 kilometers more in this next curve. And so staying on the safe side while at the same time expanding the limit requires a lot of self-discipline also from us as refractive surgeons, not trying to go for the last stretch of the road.
I agree, completely agree.
That was a fantastic sort of foundation building for the rest of the talk. You've actually made it quite difficult for me now because you've somehow answered most of the questions, but I'm going to touch on something that Sam said before, which was in terms of progression, how important it is to take into account these secondary factors. Does anyone else have any comments on that?
Yeah, I would like to point out that as I became more and more confident in the crosslink procedure, and I saw that complications do occur, but they are quite rare, I try to err on the safer side. So when in doubt, I recommend cross-linking because vision lost is difficult to restore. So, for instance, in this 13-year-old case, this is, because of his age, very likely to progress. And if he doesn't end up as a soccer player, maybe he wants to become a pilot in 5 years' time, or a professional bus driver, which may be precluded if we don't do cross-linking soon enough. And
would you do cross-linking in the right eye or in the left eye only?
Actually, Renato, in such a young boy, I would do it in both eyes, and I would recommend it in both eyes immediately. Mm-hmm. That's my indication, and this has changed over the years. 10 years ago, I was more hesitant. I don't know about you.
The prima nocere, which is the basic foundation of medicine, is first do no harm. The patient is 20/15 in the right eye, and we can detect ectasia susceptibility there, but you don't need to be any PhD for claiming the patient is seeing well from this eye. And I've seen exactly like this. A colleague came to me and said, "Doctor, I saw your talk, it's very good, and I detected the mild disease in the right eye of a patient like that, and I did cross-linking. It was the Dresden protocol, and now the patient is not seeing well. What happened? Patient was 20/20 uncorrected, and now the patient's 20/60 best corrected. And it took a full year for the patient to come back to 20/25 corrected in that eye. So they neglected the other eye of the patient that was more pronounced keratoconus and needed a transplant. And I would say I would completely act differently in this case. It was a situation very similar to this one, but I would try to do even an heroic procedure in a more ectatic disease eye before a transplant and carefully follow up the right eye. When I do believe that cross-linking should be done as soon as possible when needed. And what I'm trying to find is the ways to, beyond detection of keratoconus, to get prognosis. Mm-hmm. Like in this in this left eye, the prognostic factor was very clear. The cornea was very weak, and I said, this patient needs cross-linking as soon as possible. And of course, the treatment should start with patient education. That's why we started the Violet June campaign. And understanding patient education is telling people what they have and what they should expect, and what they should do, what they should not do. And first, eventually telling people not to rub the eye. I do believe that oral riboflavin can help in such cases. And eventually a close follow-up every 3 months in the right eye will be probably, if possible, safer than doing a cross-linking. And if doing cross-linking, maybe epi-on cross-linking will be the case to go. And I do believe that we are getting closer to having a good cross-linking effect with epi-on. And I'd like to hear Farhad Hafez's comment on that, which probably will change my mind into doing cross-linking in the right eye of such patients like you're doing.
Yeah, let me add, doing cross-linking is not a black and white decision. In this case, one could do epi-on the right eye, knowing that this will be less efficacious, but also less altering his corneal shape.
Perfect.
So that's what I would do.
I agree with both of you, because just as we had one way to perform cataract surgery 25 years ago, we have customized approaches for so many different areas. And I think cross-linking therapy is going into a similar direction, in the sense that we have a multitude of protocols and we can customize the protocol we need to the patient's needs. So I unfortunately haven't seen the topography in case, but I presume it's a borderline case. I am not as reluctant anymore, Renato, to perform cross-linking in these cases, because, as you say, the recent epi-on changes are so promising that in such a case, I would be very fine doing an epi-on with reduced risk of infection, reduced risk of haze formation, and thus a reduction in CDVA. And this is probably something we will discuss in a few moments about new protocols and the future of cross-linking. I think, as you say, Renato, it's a very dynamic field, and what we decide this year can already be overruled next year, because the field is moving forward and is becoming more and more precise.
Perfect.
It seems hard to, you can't stress enough the importance of early keratoconus diagnosis and treatment, as well as the impact of missing keratoconus in the case of cataract surgery candidates. Would anyone like to comment on this?
So, yeah, I mean, we've been talking about refractive surgery a lot, and we know that probably the most common refractive surgery is cataract surgery. And my protocol is for all of my cataract patients to get actually a pentacam on, or some kind of shine fluid imaging, which we have the pentacam, and diagnose. And I've been surprised by the actual prevalence of subclinical changes on the posterior aspect of the cornea in these patients, and it really helps me decide on inclusion or exclusion for certain presbyopia correcting lenses. Certain lenses are very, very sensitive to any kind of corneal aberration. And I will very, very easily talk a patient out of a light splitting presbyopia correcting lens in the setting of a posterior change on their topography or tomography, excuse me. So to me, back to really the original question is, what's the prevalence? I think the answer lies, closer to the 1 in maybe 20 to 50 versus 1 in 2000, based on, actually looking for it more and more. I'd be, and then the other impact is, on incisional surgery for these patients. Do you opt more towards, a toric lens? Unfortunately, in the United States, we only have, moderate to high powered toric correction in IOLs. We'd love to have the low toric lenses that you guys have in some of your clinical locations. But really, how do you counsel a patient on a limbal relaxing incision in the setting of, even though they may be 70, are they still at risk for progression because now they have some possibility of weakness in their cornea, even though they may be quote unquote naturally cross-limbed?
Yeah, I couldn't agree more. If you diagnose keratoconus before cataract surgery, it's the patient's problem, even if it doesn't progress, most likely. But if you fail to diagnose keratoconus before surgery, it becomes your problem. Maybe you have implanted a toric lens, and then you realize that this toric lens is indeed counterproductive. It may be adding to the problems of the patient. So I think it's wrong to do toric lenses without getting keratoconus diagnosis or rule out keratoconus before.
I would add to the point that I really like your statement that the most common refractive surgery we do is cataract surgery. Refractive cataract and refractive lens surgery is definitely the most important opportunity that we have for helping the patient as a refractive surgeon. And when you think about refractive surgery, many people still believe in corneal laser vision correction. They even don't think about phakic IOLs. And the screening for keratoconus is so relevant for those patients because if you do, for example, they do a lot of limbal relaxed incisions, the stigmatic keratotomy. If you don't screen for that, you have unpredictable results. And also, the corneal optics will be fundamental for the performance of the patient. And if you think the most important things in cataract surgery is related to dry eye evaluation and subclinical keratoconus evaluation as well. So we need the same multimodal imaging that we do for laser vision correction in the cataract surgery domain as well. And I think this should be more and more emphasized as part of the planning that we have for cataract surgery.
With this in mind, can I ask them what are the key methods of detecting keratoconus? What are your personal preferences?
So, I mean, currently for us, it's using some kind of shine fluid imaging, certainly family history. We look to incorporate genetic testing here in the near future. You know, but as we talked about, it's multifactorial, and you know, I think Renato's case sort of highlights that it's also asymmetric. And you know, I know there's some that believe that keratoconus can be a unilateral disease, and it can be debated. I think it's bilateral always, personally. And so, you know, it's one of those things that you really have to individualize it to the patient, much like everything else we do in ophthalmology. There's not a one size fit all, and that's been sort of, I think, said loud and clear here in this panel.
Considering unilateral keratoconus, I would say that we have now a consensus. Since 2015, we published a consensus on, and one of the topics that we really debated about was unilaterality. The disease is definitely asymmetrical, but it's possible to have unilateral ectasia, not unilateral keratoconus. Keratoconus is by itself a definition of a disease that is bilateral. We should not think that the right eye has different genes than the left eye, because keratoconus is a genetic disease. The point is that we can have ectasia due to a mechanical factor only in one eye. The complex situation is that I think we can have ectasia in both eyes. In those cases, they present as the typical keratoconus. And eventually, if you understand beyond the surface topography and tomography, eventually, as you said, to the domain of the genetics, we will be able to titrate what is a clinical bilateral keratoconus, which is a redundancy, and what is a clinical bilateral ectasia, and the prognosis will be important because we need to go beyond, not over, topography, shine fluid tomography, epithelial thickness with the OCT and high frequency ultrasound. We have point of biomechanics with the Corvis, the ORA, the Brillouin, which is probably coming soon. We have many tests. Wavefront analysis can help you. Axial length, all of this data can be integrated for you to understand better the patient. But we should do as best as possible to try to understand what the patient have and what the patient needs. And eventually, those prognostic factors may be very important in the future.
looking at the whole issue from the purely daily clinical grind, I've left Scheimpflug imaging as my primary method about a year ago, and I'm more focused on OCT-based, placebo-based topography, because we all know Scheimpflug imaging has been their gold standard in topography and tomography for more than a decade. But it is all based on an image, on a camera image, and images can be distorted by diffraction of light. Diffraction of light happens in haze, happens in scars. So what I have noticed in the past years, we have an OCT-based, placebo-based topography system, the MS39. I'm not a consultant for them, but I have all sorts of machines, and when I compare the Pentacam images I have with OCT-based images, then they are very, very similar in transparent corneas. There I have no issue. It becomes very interesting when there is any type of haze post-operatively after refractive laser surgery or after cross-linking, where all of a sudden I have not half a diopter, I have 3 or 4 diopters of difference between the images. So the Pentacam image shows me an artificial steepening that comes from the increased haze, which is natural at 1 or 2 months after cross-linking. At the same time, I love to use the Pentacam because it has the densitometry module that helps me understand the nature and the severity of the haze, and then I can adapt my steroid regimen. But at 6 or 8 weeks after cross-linking, I cannot trust the anterior data if there is a lot of haze in densitometry. Then the OCT has a clear advantage. Other than this, I would love to hear Renato's thought, because we know that keratoconus is not a disease of the form of the cornea. It's a disease where the cornea is too weak. So first we had topography, then we had topography and tomography. We saw the back surface. Then we had the first devices that are able to measure biomechanics. The next steps will probably be biomarkers and genetic testing. And the more we progress in this line of events, the more precisely we will be able to screen at a very young age, starting with the genetics and then go over biomarkers to the cornea as a structure.
Very well said. I think as we understand more, we get to be more aware that we need to understand even more. And I think when we get the biomarkers, genetic testing, we'll be able to eventually predict the future for those patients. I used to believe that it would be a form-fruit keratoconus or unilateral ectasia. Now I think it's like a continuum. So we should understand the ectasia susceptibility of the patient, and beyond the ectasia susceptibility, what the patient has as the impact from the environment. So I think it's a very evolving field. As you said, we are progressing fast, and we should not be kept fixed on basic and rigid definitions, because things are changing fast. But the basis is to help the patient as best as possible, so that we teach them about the disease, and we do it as best as possible for decision making on what is the best regimen for treatment for the patient.
Yeah, I would agree with you and with Farhad. And let me point out this parallels that exist to glaucoma and glaucoma treatment. In glaucoma, we don't wait for vision loss before we start treating, but at the same time, we look at the prognosis for this particular eye, depending on age and IOP and whatsoever, and then we come up with a custom-tailored approach for the aggressiveness of our treatment. And I think the same applies to keratoconus and the treatment of keratoconus. So not doing surgery isn't equivalent with not harming the eye. Just waiting could harm the eye as well. But if you're quite confident that this eye won't progress, maybe in a 70-year-old cataract patient, then you don't need to do keratoconus cross-linking. But if you are not so sure, based on the rapidness, the the history of the patient, the family history because of neurodermitis, eye rubbing, whatsoever, then you may be more aggressive with your treatment, even if those tomographies and the imaging of those two eyes of these potential patients are the same. So it is not only getting the images and getting the objective findings, it is our interpretation of their prognosis that makes the difference.
No, thank you for that. It keeps cropping up time and time again, is genetic testing. Does anyone have any more thoughts on that? Is this going to be a bit of a game changer?
I selected a case just to show about this, and if I may share my screen again. So this case was already published in the International Journal of Corneal Diseases. This case is a bilateral form-through keratoconus in a twin sister, identical twin sister from a patient that had a very asymmetric presentation. So this is the front surface topography from Placido, and this is the topometric map from the Scheimpflug imaging. And in all the four eyes, the tomography and biomechanical index are abnormal. So we also have abnormalities, subtle abnormalities on tomography that was published in this report. But I got the genes, the genetic material for sending to Avellino company back a few years ago. And it was, in the first time, I must say, frustrating for me because they came with tons of data, but no practical information. Actually, they said, oh, we confirmed they are twin sisters. And I said, we don't need testing for genetics for that. They know that since they were born. But a few months later, a few months ago, they sent me this nice report. This is the AVA gene, and they found interesting susceptibility. So what I do believe is that this second twin sister, she said, I never rubbed my eye. The first twin sister, she says, I rubbed much more my eye, and the right eye, I rubbed more than the left eye. So I really don't know how to interpret if those genes are related to a high predisposition for the patient to rub the eye and to have allergy and inflammation on the surface, or if those genes are related to a thinning pattern that the patient would have, like a change in the corneal extracellular matrix susceptibility. So those will be the next questions that I would ask for the genetic testing so that we understand that more.
So yeah, I mean, I think the jury's still out on how this is going to impact our decision making for our keratoconus patients. I look at it as, you know, another piece of the puzzle. I don't think it's at the point yet that it's going to be an absolute yes or no crosslink or no crosslink or, you know, whatever treatment you want to do. I do think that it will help us better sort of understand patients that, you know, if everything else is the same and you're deciding, should I do LASIK on this patient or not, and they come back with a Avogen test that is very highly correlated with or very highly at risk for keratoconus, maybe you sit and watch that patient a little bit. I think that in patients that, you know, have keratoconus and they have siblings, I think that's going to be an easy place for us to start to incorporate this test and figure out, you know, what information it's giving us, and then follow these patients. You know, I think with time, we'll have more and more case reports and probably some type of registry or something where we'll say, okay, this patient was very highly positive on the Avogen test, and they did show, you know, clinical disease, or they did show, you know, disease on their testing, and then there's other ones that didn't. And with that, we'll be able to understand the test, just like, you know, with, you know, for instance, Scheimpflug, it's come a long way, right? I mean, the initial pentacam that we had and the current one, you know, the information's sort of been there, but we haven't been able to really understand it as well as we do now, without having many patients that we've looked at and seen how they've done, and then been able to sort of interpret that data. And I suspect that that's going to be the same for genetic testing. But I do think that it does give us more information, and more information can be helpful. Sometimes it can be confusing, but I think by and large, it'll help us help our patients.
I would just be very curious to understand how this relative risk has been determined and assessed, because this is exactly the thing that we as clinicians have been struggling for decades now. As Renato said, we have not one factor, we have a dozen factors, and now we have patients with a point mutation. And then one of the columns says low, intermediate, or high risk. But how do we determine this other than with validation through clinical data? And each of these patients can have 10 other confounding factors, because we know that the disease is in the end multifactorial. And to my knowledge, none of these missense mutations have been analyzed in cohorts that large to allow for a clear and distinct low, intermediate, and high risk classification. Maybe I'm totally misleading here now, but I would just be curious to understand who has established these relative risk terms and gradings.
Yeah, I don't know for sure, honestly, but I do think that, again, that's why I don't think you can take it with, blind faith. I think that you look at it and, we know that every test has some kind of noise and validation. And, it's early. I think it's early. I think anyone who says, I'm going to trust this wholeheartedly, I think is probably, I agree with you. I think there's still a lot to be learned with the test, but I think getting the data is important.
Yeah, but we should just, as you say, Sam, we shouldn't forget that there are target loci identified. There are no target genes identified yet. And that's a big difference. And so hopefully in the near future, we will have much more detailed information based on these testings.
Thank you. Our next discussion point kind of leads on quite nicely from that, and it's more future facing. So what are the latest innovations in corneal cross-linking for keratoconus? And since we have such a wonderfully global panel here today, do these innovations differ slightly from your regions of the world? I'm sure you'll have some very valuable input.
Well, I can say we're probably the furthest behind. FDA approved is only really the Dresden protocol. So there's all these other things that I'm very jealous of what you all have across the globe with respect to options for an approved version of Epi-on, accelerated, pulsed. There's so many different options that are possible with this. So I'll leave it to you guys to talk about this, because for us, my experience has been largely with just the traditional, which works really well, Dresden protocol, Epi-off protocol.
If I may, I suggest I give like a wish list, and I think Farhad, maybe Sophie can also help me with a wish list, and Farhad will come with his answers, because he's been involved with the cross-linking since the very beginning, and his active research is really cutting edge. And I always learn tremendously when I see him, Cosimo, talking about the new things on the Epi-on and how to adjust the fluence for thin corneas. Those cases, they really benefit, and we come with wisdom that we can apply in the practice the next week, which is great. So my wishing list is first to have Epi-on cross-linking. I think Epi-on cross-linking is definitely the next barrier that we should go through. We already have thin corneas. We can do very well for thin corneas, and we may have some benefit from the customized cross-linking and eventually adjusting cross-linking for improving the corneal shape. And this may be another area that I would like to see. But turning the page, my question is, if riboflavin with UVA and oxygen, and Farhad was one of the first to point for the importance of the oxygen, if this will be the main cross-linking procedure that we'll do. We have other ways of inducing extracellular matrix cross-linking in the cornea, and eventually how those are coming in the future, and how we'll adopt them into our practices. And finally, I'd like to see ways of using easy things for the patient to benefit from cross-linking, like oral riboflavin and other types of enhancing diets that can improve the cross-linking procedure, not to be needed as a procedure, just to a change in habit for the patient to be benefited. And that's maybe with a huge impact for the global incidence of keratoconus.
So what Renato has just said, I think, is on our wish list of anybody who does cross-linking. Epi-on cross-linking would be really, really nice to have. And we've been trying to do successful Epi-on for a decade now, and effectively in 2021 now, I think we finally have an Epi-on that is not only efficient, but is also easier to perform. As Renato has mentioned, we need UV light, we need riboflavin, and we need oxygen for the process. Now, in Epi-on, we all agree why Epi-on would make more sense. In Epi-on, the epithelium is a barrier to both riboflavin and to oxygen. The riboflavin issue had been solved a few years ago with iontophoresis, so with an active transport through the epithelium, but that's bothersome as a surgeon. If you ever have tried to put on this device, it falls off, it loses suction. It's just sometimes messy. But we have learned so much about penetration enhancers and modifying epithelial permeability that now I've spent personally almost 14 full single days at the multiphoton microscope of the Swiss Federal Institute of Technology. And we now have the same levels of penetration through the epithelium using penetration enhancers as we do have with iontophoresis. So that's a good point. The second one is, yes, oxygen is essential. We were able to show this 8 years ago. And so some groups have said, if you need more oxygen, why don't we accelerate the whole thing and put a stream of oxygen over the cornea? And yes, that works. But again, it's probably not the best solution when you are in Zambia or in Bangladesh or in any remote area of the world and you need yet another technology. And it's not about giving more oxygen to the cornea, but performing the whole procedure in a way that enough oxygen is available at any given moment during cross-linking. And all the single issues we have tried in the past, which is acceleration, pulsed light, and higher total intensity. If you take these pieces of a puzzle and try each one of them, it doesn't work for a successful Epi-on. But if you combine them intelligently, which means higher fluence to compensate for the epithelium, very gentle acceleration, not an exaggerated one, so roughly 18 milliwatts at 14 minutes, and pulsed light to allow for a little more oxygen diffusion in the off period. Each of these factors alone is not sufficient. The combination, along with penetration enhancers, has led us now to functioning Epi-on. Cosimo Mazzotta, as you have mentioned, has worked a lot on it on the direct clinical level. I have done a lot of stress strain measurements, and we do have very convincing results now. And Cosimo, I think, has published 3-year clinical data using Epi-on without oxygen boost, but with iontophoresis. And we have the same amount of stiffening now in the lab without oxygen boost and without iontophoresis, just by dropping penetration enhancers and being really wise with the selection of settings. So my dream is the same as Renato's. I'm convinced that we can do bilateral Epi-on in 1 or 2 years. And imagine how simple it gets then. And then everything Sufi has mentioned will become easier, because if you see a patient at risk and you know that the risk profile for doing a cross-linking is even lower than it was before, then I would very deliberately treat the patient. If the risk for haze is lower, then I will treat the patient with a really good CDVA to begin with. So I think Epi-on is the key element to make cross-linking a real global weapon.
I absolutely agree with you. Epi-on is needs to be improved. We have been using Epi-on for a couple of years, but always stressing it is less invasive, less effective. So this there is room for improvement. However, we are lucky enough to have all the options because we are outside of the FDA regulations. So we can do Epi-on, Epi-off. We can do, based on your research, Farhad, we can do thin corneas because we manipulate the parameters, and we can do pocket cross-linking. We can do laser abrasion, the Cretan protocol, just for removing the epithelium, and some stroma. And this is something that is not possible with epi-on cross-linking alone right now. I mean, stopping the progression is one thing, improving the corneal shape is another thing. So what we try to do in frank and progressed keratocony is to regularize the cornea by doing some laser abrasion in PTK mode, not as a refractive procedure. The aim is not to get rid of spectacles, but the aim is to improve the corrected vision, improve the tolerance to contact lenses. And this is something we do routinely. And I think this could be enhanced by custom cross-linking in order to shift the apex from down below or inferior temporal to center again. So I think this can be combined, this approach can be combined.
Oh, absolutely, Sophie, I agree with you, but I think we speak on two different levels, because yes, what you do now, you are a Formula One driver, taking your racing equipment, exactly knowing where the limit is. And I think on a global level, the eye doctor who doesn't even have an excimer laser would be happy to perform a safe, low infection risk cross-linking. So these are two
yes,
approach, and one only stops the disease, the other takes care of visual rehabilitation, which we haven't spoken about yet.
Yes, the combination of cross-linking with other procedures is one of the hottest topics. We implant a lot of rings here in Brazil, and we use the femtosecond laser, at least myself, as a mandatory for those cases. This is the only application of the femtosecond laser that I exclusively use the femtosecond laser as the only way of doing the procedure. I can do cataract surgery. I even can do LASIK. I don't do LASIK with a keratome anymore, but I would say that the rings is the only mandatory way of using the femtosecond lasers. But combining cross-linking and intracorneal rings is still an area that we should learn more. And it's hard because keratoconus is a complex, it's a multifactorial disease, and we don't have patients similar. We can find similar patients on topography, but they would change tremendously on other factors. And learning about visual rehabilitation along with rings, excimer laser custom ablations, and cross-linking should be an area for further development of protocols. But I would say the basis is having the patient to be benefit on what they need and what they should have instead of what's possible to have.
Sam, I feel you're a little shortchanged there by being from the US. Do you want to share your keratoconus wish list? Is there anything you're looking forward to in the future, or what you'd like to see?
I mean, I think these guys have hit it on the head. I mean, really what we're looking for is something that's, I think ideally epi-on, safe, effective, and efficient, right? I mean, if you can do that, then you can bring this to the masses, which is really what we need to help these patients. And certainly then you're going to have centers of excellence where you can then do more customized treatments to get them, better quality of vision. But really the first thing is to stop the progression. And once you do that, then you have options down the line, whether that's, surgical or non-surgical. There's all kinds of advances in contact lenses and whatnot that these patients then, and hopefully they don't need those advances. They can stick with, conventional contact lenses or glasses. But that's really the hope. I mean, all the stuff that, Sufi's talking about is amazing. And the combined treatments are amazing. But I think to Farhad's point is, if we need to make sure that whatever we have, that, the ophthalmologists in the small town in Central US, Central Asia, Central South America, Central Europe, has access to it and feels comfortable performing the procedure just like they do with cataract surgery. And perhaps you don't need to be a cornea specialist to do this. You can do this as a general eye care provider because it's become so straightforward, so safe, so simple, and so effective.
Sam, I couldn't have said it in better words. I just want to give one last statement from my end, because it's exactly as you say, Sam. I think everything we've discussed in this hour concerns the maybe 20% of the world population that have access to all this high-tech medicine. The other 80 just simply do not receive anything. So my ultimate wish list, and we've been working on it for a number of years, is to bring this technology to those who are underserved, which means radically decrease the costs related to the procedure, take it out of the OR. We are taking out IVTs, for God's sake. It's office-based now. We are taking out cataract surgery of the OR and do it office-based. We can do epi-on cross-linking office-based. And this is one of the main reasons for my personal motivation to bring cross-linking to the slit lamp, because my dream is to do bilateral epi-on at the slit lamp in a simple and effective way for those who cannot afford it until now.
Well, my wish list is probably more simple. My wish list is related to a patient education global campaign. I think I just saw a patient yesterday that came with her husband, and they were really terrified about the word keratoconus. They go to Dr. Google and they think they will get blind, they will need a transplant. And they were very well educated. Both of them are school professors, and they didn't know about the disease. They are just worried about a problem that does not exist. And I think if you want to help the patient, start by telling about the disease, and a global campaign may help tremendously on this sense. So if we join forces to educate people about what is keratoconus, what we can do as what we have improved, and eventually doing this global screening tests so that we can work effectively to prevent vision loss from corneal ectasia, I think that will be my main wishing list. Because all the other wishing lists, epi-on, all the advances in imaging, combined procedures, we already have them. They are coming. So you should not ask to the genius the things that you already are going to have. I'm asking for the things that I don't see they are coming as an obvious thing.
Sufi, do you have any closing remarks?
Well, I couldn't have said it better than my previous speakers. I learned so much from those experts. Thank you so much. It was fun.
Okay, wonderful. Well, I'm afraid that's all we have time for today. So I want to thank our panelists again for their invaluable contributions to this conversation. I learned a lot, and I'm sure everyone else did too. And I'd also like to take the opportunity to thank our sponsors, Avellino, Oculus, and Glaukos. So from everybody here at the Ophthalmologist, I'd like to say thank you for listening and take care.